So good afternoon, good evening, good morning, everyone, from wherever you're joining us. And welcome to the Africa Research Echo 2024. This is going to be our very first session, and we are kicking it on a high note, joined by three technical experts who are very experienced in their field of practice. We're going to be discussing today the HPV vaccination, bridging the supply gap for HPV vaccinations in Africa by addressing access, availability, affordability, and acceptability. It gives me great delight to welcome you all because this is the first one that we are also discussing cervical cancer, recognizing that this is the Cervical Cancer Awareness Month. And we are expecting more people to be joining us as we go along, but I'll just do a quick round of bit of housekeeping. Please remember to mute your microphones if you're not speaking. If your bandwidth permits, we would love to see your faces, so kindly put on your video so that we can see you. It helps to make our sessions more interactive. At all times, do use the chat to introduce yourself, to ask questions, to make comments. If you get impressed by something that the speaker has spoken about, please do comment on it. And at the same time, please, if possible, you can enable subtitles on your screen if needed. The session is being recorded, and the recordings are available on a link that will be shared on the chat by the Secretariat. The Africa Cancer Research and Control ECHO program is run by KENCO, the Secretariat, in collaboration with the Project ECHO. Today's session highlights the gaps, opportunities in cervical cancer elimination through HPV vaccination. We're looking at increasing awareness of what our partners and stakeholders, including Gavi, as well as the WHO, has in terms of tools and capacities that can support national cancer control planning processes, as well as tools that can be utilized in micro-planning for HPV vaccinations in country. My name is Benda Kithaka. I'm the chair for the 2023-2024 Africa Research ECHO, based here in Kenya, but working with teams across Africa so that we can be able to make this ECHO well representative. We will be joined today by Dr. Shinkafi Bagudu. She's the founder of the Medicaid Cancer Foundation, a medical radio diagnostics and clinic and diagnostics and service delivery clinic in Nigeria. She will be talking to us today about what their experience was in introducing the HPV vaccination in Nigeria just last year. She will take us through some of the challenges they face, some of the opportunities they had, learnings that we can take on from Nigeria as we're looking at the rest of African countries that have not necessarily introduced the HPV vaccine. Dr. Bagudu is an expert in advocacy as well as in service delivery across Nigeria. She also is the chair of the First Ladies Association Towards Elimination. And I think she will be giving us the case presentation for today. After that, we will have Dr. Frederica Tauch, a senior specialist at access to funding in Gavi, funding design and review team. And we'll also have Dr. Hiroki Akaba, an obstetrician gynecologist from the World Health Organization. We will be sharing their bio as we go along. So without further ado, because we are starting rather late, 10 minutes late, I would like to invite Dr. Zainab to take us through her presentation. After this, we will have the Q&A together after all the presenters have presented. Kindly do pay attention to what our very experienced speakers have to give us today. Dr. Zainab, over to you.
A very good afternoon from Abuja, Nigeria. It's a pleasure. Thank you for the invites to this meeting. Like Benda has said, it's a very important way to start the year, and also as we mark the Cervical Cancer Awareness Month. I'd like to share some slides as I take you through my talk. Indeed, Nigeria is one of the countries that got on the HPV vaccination train a bit later. but better late than never, we always say. Last year in November, we started the vaccination. Okay, so I can just scroll through. Can you see my slides, please? Just give a little nod. Yes?
Yes, they have been visible.
Yes, okay. As a background, we all know the human papillomavirus is definitely the implicating virus in over 90% of cervical cancer, and there are different serotypes. In Nigeria, we do have a high prevalence rate as the most populous country in sub-Saharan Africa. It's now the cervical cancer, which is caused by HPV, is now the third most common cancer in both sexes and the second in female. It was surpassed by prostate cancer in the last Global Count reports. Over 12,000 women are diagnosed, and this is grossly underestimated in comparison to the thousands more that we know remain undiagnosed and unscreened. With this 12,000 being diagnosed, we encounter about 8,000 deaths in our population. Despite the alarming statistics, like I said, we've just introduced the vaccine in some states, 16 states, I believe it was, and it was as a result of partnership between our federal government and Gavi, the Vaccine Alliance. It was available, but only out of pocket and with low coverage levels. As of 2020, this disparity is not unique to Nigeria alone. It is a disparity that many low-middle income countries are facing. And as of 2020, statistics show that only 30% of the countries had, in the low-middle income range, had started the vaccination. There is an obvious and concerted efforts to improve this now compared to 85 in the high-income countries, as we've seen many more countries from the low middle income brackets joining the vaccination train. So what were the barriers? If I start with the barriers, first of all, the lack of availability of the vaccine, which was related to financial constraints. And even when the vaccine came, the issues, a lot of states had to pay counterpart funding, which is not unusual for a vaccine rollout or even routine vaccination. For every routine immunization round that is going to be held, the state government, Nigeria has 36 states, the state governments have to pay a counterpart. The government have Gavi, have done their own, and it's available at the primary healthcare agency, and they distribute it to the state. But beyond that, they have to own it to an extent by putting some funding down to ensure that it goes wider. I was on the committee for the introduction nationally, and we had a very slow uptake or slow in the vaccine cold chain. Not all the states had availability of an effective cold chain. So this led to problems. And then from the state, don't forget, we have to travel right to the interior. And this involves having vehicles, fueling the vehicles. There are a lot of hard to reach areas in different states. And that was a problem. This global vaccine supply constraints, I think we're overcoming it globally. There is more production. There is the new SAGE guideline of 1 dose is sufficient to prefer adequate protection against cervical cancer. And then, of course, political will is always at the brunt of everything. I think that maybe I should have given you a little bit about our work. We do a lot of advocacy in the Medicaid Cancer Foundation, as well as implementation of various programs. And cervical cancer is one of the cancers that we focus on in women, and breast, of course, which is the commonest. We've been able to, aside from raising awareness, we carried out the only documented pilot study of the vaccination for girls aged 9 to 14 in a school in Kebbi State, and this was published in a journal in 2022 last year after the successful rollout. And this was also the only published publication that we were able to use as a country for the country proposal of the vaccine. In our experience, the uptake or the demand generation was reasonable. It was a pilot study, and then we also went to one school, but the acceptance, should I say, more than demand generation, was quite high. After engaging the right stakeholders and I'll talk a bit more about that as we go along. And we still get all the calls from the various people in the area, Yauri local governments of Kebbi State, to come and complete all the other girls. But of course, now Kebbi has been included and had 80% coverage as well. So we were also a part of the pre-introduction training. Members of Mediaid were trained nationally alongside other civil society members on demand generation. And we were very prominently at the launch in the presidential villa in November 2023. Was it? It was in November. Sorry, that's an error. It was in November? It was in November, I think. So the launch, the good things, I'd say the positive things about the launch is that it was a very high level launch. It was attended by high level stakeholders such as the First Lady. We had ministers of health. We had representation from the traditional and religious institution, reflecting the diversity and the complex nature of Nigeria. At the highest level of both religions were present at the launch and spoke very much in favor of the vaccination. We also heard from all the partners, Gavi, UNICEF, all the people that were able to share the data across the world of HPV vaccination and how relevant it was and how useful it will be in protecting our girls. We also had a lot of widespread media coverage, both on national and local TV stations, to emphasize and further amplify the milestone achievements. I think I'm going to... In Kebbi State, the introduction was covered 3 areas. Of course, like I said, media, advocacy, stakeholder engagement, and then community engagement. 2.9 million people were reached across the 21 local government areas through the media campaigns, and there were repeated engagements, again, as shown in the pilots, with the traditional and religious rulers, the district heads, and all those that were involved. The training at the local government level on injection safety was also, these are all the things, and waste management, cold chain evaluation. These are the parts that the state government has to come in and fund. I want you to hold that training at local government level in your head, because this. The challenges faced, of course, this is something we see everywhere, the misinformation. The misinformation was enormous, and the misinformation hit us after the launch. It was almost like they were waiting, and the minute it was launched and going around the country, it just hits the waves, and it was massive. This led to vaccine hesitancy and influenced, of course, the uptake. I have people, my sister was not ready to vaccinate her daughter until I gave her more information. And this is somebody who is very well educated, and it was being offered to her daughter in the school, but she wasn't having it until we were able to give more information. In a way, of course, the cultural and religious beliefs makes it easier for this misinformation to come into play. And also, it was played on by the people that were fueling the misinformation. It came up as soon as it was launched. There were big radio shows that have huge, massive followers that started to attack the efficacy or the intentions of the vaccine and of course, the usual stories of how it's going to cause infertility amongst the young girls that were being targeted. The cold chain logistics, I've spoken about that, not always working, not enough funding to get it going and working properly, and getting to the inner states, inner parts of the states as it needed to, because we can't just vaccinate schools in the capital. We have to go to all the local government areas. By far, the most challenging and what was most painful to me personally was the health worker misinformation. It seems that we failed on educating our health workers adequately. A lot of the misinformation was actually traced to come, and I'm not just saying this anecdotally, to come from lower end health workers, the CHUs, the midwives in the interiors. They were the ones on WhatsApp groups spreading the misinformation and fueling it amongst the population. Having said that, though, we achieved reasonably good coverage. It was over 80% average, and these are the 16 states rolled out. You can see some as high as 98. The more informed the states were, the lower it became. Or should I say, the more work we had done previously, to the lower the vaccination coverage was. I think Kebbi ranked around 80%, and Kebbi is one of the most informed states in Nigeria when it comes to cancer. Lagos State is what you see at 36% here, which is sad really, because Lagos is the capital of Nigeria, and it was the capital, but it's the commercial capital, the hub of all the business and activities, and where a lot of our educated people reside. This means they also have the funding, the capacity to access the internet and read all these things that is causing the problem. So we believe that is what caused the problem in Lagos. For some of us, the other states, Enugu and so on, they had inadequate vaccine, they had inadequate cold chain. For Kebbi, one of the reasons that I was given is that the vaccines were actually not enough. So that might be a good way, a good reason. So the way forward, we need to properly sensitize the public, and these health worker education that I have been stressing, we need to work harder on it. We take it for granted that the health workers know, and we don't always we train them on injection safety. Like I said, we train them on handling the cold chain, the solar fridges. But do we actually ask them what their beliefs are about these vaccines, and what they understand on the level? Because it's not, we're talking about a cadre, the RI officers that are not trained or have not been taught in their own curriculum about the pathophysiology of cancers and things. And they know that cancer exists, but what are their beliefs and what efforts do we make to dispel them? We need to put a lot more effort into that. And this responsibility lies with the health agencies, with the state governments, and also with the civil society, of course. At the grassroots level, yes, we need to implement and use partnerships more efficiently. I mean the local partnerships with the rulers, partnerships with the community groups and the associations that are involved in disseminating not just health information, but information about what empowerment scheme, information about water sanitation and things like that, or even just social groups that the women have and all over the villages. We need to use those institutions properly so that we can educate them and we can have better outcomes. Evaluation and close monitoring, I'd like to say that we're doing reasonably well on that. Especially when it comes to having the next round, in the case of this vaccine in March. And the data, as I showed you, is quite robust. I've seen the full report, and we have a really good data that has been generated from the first round. Improving the vaccine logistic and cold chain system is always necessary, and it's always important for us to do that. in Kebbi, we've got, I believe, 6 states in Nigeria received Gavi support way prior to this on health system strengthening. And some of this included the distribution of solar-powered fridges for keeping vaccines and also constantly training the healthcare workers. But I believe that that is one of the areas where we have failed to include things like awareness, the work that the civil society do with the ordinary population. We're training them, like I said, on injection safety and how to keep the solar fridges healthy, but we're not training them on their beliefs and dispelling the misconceptions that they have ingrained in their mind. So thank you. We look forward to the next round in Nigeria. We had a very good first round, and it is my belief that despite all the misinformation, we were able to give over 4.6 million doses in total in the country. And with that kind of number, we will be able to get there to the elimination goal targets that we need to soon. One thing I didn't mention is bi-gender vaccination. There might be a place to consider bi-gender vaccination in our populations, particularly in Africa, where there's always that suspicion when you're targeting girls, pre-reproductive age girls, and it's thought that we're going to sterilize them. Cameroon did it quite well. After the failure of the first round, they introduced bi-gender. Countries like Senegal are not doing so well. I was in a meeting in Francophone Africa in December, and the data from those other countries are not as robust as some of the others in the middle-income countries. So thank you very much for listening, and I'm happy to take questions when Brenda is ready.
Thank you. Thank you so much, Dr. Bagudu. That was quite insightful. Some things have stood out for me. For example, the assumption that any healthcare worker would know about the vaccine, and therefore they will be the first one in the front line recommending the vaccine. And of course, the other insight was that the higher the awareness, the higher the knowledge of cancer, the lower the uptake of the vaccine. That's something that needs to be investigated further. Thank you so much. Our next speaker is Frederique. Frederique is a senior specialist access to funding at Gavi, the Vaccine Alliance. In her role, she's responsible for managing and evolving Gavi's application review processes, including the functioning of independent review committees. She joined Gavi in 2016 and has been leading the funding design work over the last years. She brings 20 years of experience in program management, international development, and health financing. It's delightful to have Dr. Frederique here today because we are talking about HPV vaccination, bridging the supply gap for HPV vaccinations in Africa by addressing the access, availability, affordability, and acceptability question. Frederique, over to you. Thank you.
Thank you so much.
Dr. Bagudu, you may want to remove so that she can put up her slides. Dr. Bagudu, your slides are still up.
Yes, we're on it. Stop share. That's it.
Thank you. Thank you so much. Okay, Frederique, over to you.
Yes, one moment. I'll just put the slides into presentation mode.
Yes.
Yes, you can see it?
Yes.
Great. So thank you so much for having me here this afternoon. As was already mentioned, I'm working in the Gavi team, which is actually organizing then the review of funding requests. And before that, we are coordinating across the House on the guidelines which are issued on how to access Gavi support. So I think I don't need to give an in-depth introduction about Gavi, but you know it's kind of a multi-stakeholder alliance bringing together organizations, stakeholders interested in saving lives, protecting people's health by increasing the equitable and sustainable use of vaccines. So over the years, we have added a number of vaccines to our portfolio. Some years ago, we also added HPV vaccine. Then what happened was that there were some challenges, as you might be aware, around kind of availability, market, and obviously then the COVID-19 pandemic, which resulted, unfortunately, in a slower than expected uptake of HPV vaccination we have seen. Thus, the Gavi Alliance has adopted the scale-up of the HPV vaccine as a must-win priority. That decision was taken then a year ago approximately, and resulted in a number of discussions across the Alliance initiatives and thinking kind of how can we support that, noting that HPV vaccination is one of the most impactful vaccines actually in our portfolio. So what we call the HPV Revitalization Initiative is really about accelerating quality HPV vaccine introductions. It also includes then the rollout of the multi-age cohort efforts, which had been put on hold in many countries. And for those countries which had introduced already kind of a rapid coverage recovery, because we noted that a lot of programs, they suffered over the last year kind of due to COVID. There was some setbacks there. And obviously that is kind of generally for Gavi, sustainability through this integration into the EPI program is an important consideration. So the goal which has been set by the Alliance is actually to vaccinate 86 million girls against HPV by the end of 2025, which is an ambitious goal, but also something which is considered, we can do it. If we kind of all come together, we can make this happen. So I'm going to spend now a little bit of time trying to explain what is the type of support Gavi is providing. So, and bear with me kind of when there's a few slides I'm going to go through very quickly and some I might pause on. So the thing is to distinguish is a little bit the different scenarios countries find themselves in. So I said there's some countries who never introduced the HPV vaccine. So there it's obviously kind of, we want to support those countries who are interested in a kind of high quality application and kind of a really successful launch. And that may include an initial multi-cohort. Now then we had some countries which had already introduced into the routine immunization program, the HPV vaccination, but they were never able to conduct actually a multi-age cohort. So we also want to then support these countries to actually complete their multi-age cohort campaigns and ensure kind of the strong and sustainable routine deliver. There's also a component you might be aware of that in between the SAGE guidelines has changed with the permissive one-dose schedule. So there are also these countries which may actually consider switching to from 2-dose to 1-dose schedule. And that is also a question then for those countries which have already introduced, where we of course want to maintain, ensure kind of we have a really strong delivery and the switch question is pertinent. Now, when we try to map this across these scenarios across the African continent, we see that we have countries falling into different categories. Here you see the latest list we had at hand is kind of to see kind of which countries have actually not yet introduced HPV, which ones have introduced, have already decided to move to a 1-dose schedule, or which are kind of on a 2-dose schedule. And what is maybe to making things then complicated to understand at first glance is that depending where countries are here, they might benefit from different Gavi support. So, which brings me then to this chapter on the what Gavi is support is available. So, which actually, and I put this up front, is described on our website in our guidelines. So I put here the address. There's kind of on our website, there's a link to all the guidelines. And there are some obvious the kind of top guidelines about like the application process, but then kind of specifically the vaccine funding guidelines include a chapter on HPV about kind of what are the funding opportunities with Gavi for HPV. And there's also an annex in the program funding guidelines, which kind of speaks to HPV. But basically, I'm going to start with this block here is kind of to understand kind of Gavi, what can Gavi support? So Gavi supports on one side the obtaining the vaccines in itself with the injection devices. That is for the routine immunization program, that is kind of a continuous support until a country actually transitions out of Gavi support. And then there are some time-bound financial supports which are available. So for an introduction into a routine immunization program, we do provide a vaccine introduction grant. That is kind of to ensure the quality introduction, kind of these upfront, contribute to these upfront costs at the routine immunization. For campaigns, or in this case, the multi-age cohort activities, we do provide what we call operational support costs. We do also have some funding support, which is kind of supportive then when a country has already introduced a vaccine, there is a need for one reason or another, or a wish to switch either presentation, product delivery, etc., that we can have some support in the form of a switch grant to actually manage well that switch. And we do have some more kind of fundamental support, which is provided to countries for health system strengthening and targeted country assistance, which is technical assistance provided by different agencies. Now, both the HSS support and the TA support can come in and actually support the HPV revitalization efforts. And I'm going to go into a little bit more detail in the subsequent slides. Now, I have mapped here the different countries you have seen as per the different previous slide on kind of which categories they fall, and therefore what kind of support they are eligible for. So a country which has not yet introduced HPV vaccine will be eligible then to request a vaccine introduction grant and operational support costs for their MACs to ensure this kind of solid, successful introduction of HPV vaccine. A country which has already introduced, but is kind of has the MAC outstanding for some reason, they've already received in the past their vaccine introduction grant, but they would receive then operational cost support for this multi-age cohort campaign. They may also receive some support for if they are planning to switch. And similarly, countries which have already introduced into the routine immunization system and have done their MAC, they still might receive, for example, a switch grant support if they're moving to a one-dose schedule. And all countries can actually use HSS and TCA support. The process, how it works is kind of, and I'm going to start with these entirely new vaccine introductions. So country which never introduced HPV vaccine, they can come, as I said, they can request support to introduce into routine immunization programs, which could be like in line, we rely on SAGE guidelines, I have to say, maybe on all the technical elements. So the routine cohort, for example, should be in line with kind of what the SAGE recommendations are. And here in this example, it could be, for example, that the routine cohort is chosen by a country at 9 years, and then there's kind of a multi-age, a MAC for 10 to 14. And then we would kind of provide financial support for this, where we have a standard rate for HPV, where for all the routine cohort, it's actually calculated as $2.40 for each targeted girl in the routine cohort. And we do have a formula where the operational cost grant is actually depending on a country's transition status with Gavi. It's also kind of noteworthy that Gavi, as one of its principles of operating, is requiring countries to co-finance and contribute to the cost of vaccines. The percentage of contribution, required contribution in terms of co-financing, depends on a country's transition status, which is actually aligned to kind of World Bank ranking and kind of lower income countries, etc. And this co-financing of the vaccine costs is only for the routine immunization. It's not asked for campaign type of activities in our current model. And what is presented here is actually a process which those of you who have been working on with other vaccines might be familiar, because it's the same principles as for all the other vaccines Gavi is also supporting. A quick note here on the vaccines which are supported. We do have on our website, we publish what is kind of the available vaccines. This is done in close collaboration with our alliance partners, UNICEF notably, who is actually managing the kind of sort of pooled procurement of vaccines, because most countries through UNICEF. Available, what is currently available as vaccines, and it might evolve over time. Then to point out that we do have deadlines in the year when countries can submit requests for adding new vaccines into their programs with the support of Gavi. So we have a next deadline, which is actually already upcoming. It's it's already end of next week. There's another one in April, and there's in September. One always, of course, has to consider that there is a lead time for that. There's a process then to review the request, the approvals, the translating that then into grants to be dispersed, but also very importantly, issuing the purchase orders so that UNICEF actually can place the orders with the manufacturers and ensure timely delivery. So it's actually important to take into consideration the lead time for this rollout then. And kind of a note kind of that actually we have spoken before to this goal. So we feel kind of like, given this lead time, we are looking really kind of at the next couple of months in terms of applications to then kind of contribute to this goal which has been established. Now I'm going to move to those country scenarios where they have already introduced into a routine program, but they may still have kind of a delayed multi-age cohort campaign which has been implemented, and they may consider to the switches. So here I've also done put down like what is the available funding for that, which can be actually, it's publicly available in our application process guidelines, and then the vaccine funding guidelines also explained. And there's also explained that given the delay for the MAX was kind of due to very specific circumstances, in the sense that we actually got some flexibility around kind of what are the options for catching up with girls who have kind of now moved beyond the standard age range. Such requests can actually be submitted in a bundled way more frequently, because we have actually agreed a novel review mechanism which will allows us a bit more flexibility around the timing of submissions. And kind of, I'm almost at the end of my presentation. So kind of to say that I've mentioned before, there is this HSS funding opportunity for HPV. All Gavi eligible countries do have an allocation for HSS funding. So there is the opportunity when there's an existing grant to kind of reallocate resources for HPV efforts there, or kind of when there's a new upcoming grant, it can be programmed from the beginning. And if there's really no opportunity there, then actually there are, in these what we consider rather exceptional cases, there is also a mechanism to discuss with the Secretariat on possible need for top-ups. And then to mention also, I've mentioned the TCA possibilities. So that the provision of target country assistance, again, it's kind of something which is provided through the Gavi model to all countries, and one can actually see what are opportunities there generally. And then there is specifically for HPV some opportunities that there was funding, and there's kind of efforts to specifically ensure countries can access for their HPV efforts TCA support. And with that, I'm at the end of my presentation. Thank you very much.
Thank you so much for highlighting so many opportunities that exist for the countries that would want to introduce or have already introduced and are keen to do further follow-up to strengthen the HPV vaccination in country. I think I've already started seeing some questions flowing through. This after our last speaker, who is Dr. Hiroki Akaba. He's an OBS gynecologist from Tohoku University in Japan, and he's worked in National Center for Global Health and Medicine, Tokyo, as well as engaging in several health projects in low and middle income countries. Joined a mission in South Sudan as an OBS expert at Médecins Sans Frontières in 2019, followed by graduating with MSc. He's a health policy expert from the London School of Hygiene and Tropical Medicine, and since 2021 has worked as a technical officer, IVB department in WHO headquarters, supporting norms and standards setting on HPV vaccination, providing technical support to introduce HPV vaccine and improve coverage in member states. Dr. Hiroki, over to you.
Thank you very much, Brenda, for kind introduction. My name is Hiroki Akaba, currently working in the WHO headquarters, Department of Immunization and Vaccine and Biological. And I'm also aware that my colleague and topic lead, HPV vaccine lead, Paul Bluen from headquarters, is also joining this meeting. Thank you for your invitation and this opportunity, really. And today, I'd like to talk about global updates about HPV vaccine. Somewhat kind of overlapped with the previous presentation, but from global perspective, I'd like to share the current status and what is the challenge and what is the way forward about HPV vaccine. So I think all of you may already know that we have a global strategy to eliminate cervical cancer. So we have a target by 2030, 90% of girls will fully vaccinated by HPV vaccine by 15 years of age. If we achieve this goal, we can avert more than 61 million cervical cancer cases and 42 million deaths can be averted in LMIC over the next century. So we have a target, clear target, to achieve 90% goal by 2030. And the question is where we are now. So today, 2020, for January, we have 141 countries has already introduced HPV vaccine. But as you can see here, and as Dr. Bagudu already explained, you may see a little bit inequity. As you see here, a couple of African countries and Asian countries are still left behind for the introduction. Of course, we have progress. So compared to 10 years, a decade ago, we have achievement. More countries introduce HPV vaccine, which is great. But still, if you look at this blue area, this is a proportion of population of the girls who live in the country where the HPV vaccine is accessible. So you can see like only 38% of girls have access to the HPV vaccination. So a little bit, we have a achievement, but a lot of efforts needed to achieve the target. So this is the coverage. So if you think about how many girls are actually vaccinated, not like HPV vaccine introduction only. So how many girls were vaccinated 2 years ago, 2022. This is the latest data. So you can say 1 out of 5 girls are vaccinated in 2022. So we have to reach 90% for this figure. We have to reach 90% by 2030. So we need to accelerate to achieve high coverage. So if you take a closer look to the African country, I just enlarged a little bit for this map. You see a lot of countries are still, they're waiting for the introduction. The country the girls who live in these countries are still waiting for the access to the HPV vaccine. So, and also I just highlighted here, it's Nigeria. They started introduction last year, and we are waiting for the phase 2 introduction. And it's a very successful introduction, I would say. And we hope that the phase 2 introduction is going to be good as well. And for here, this is, we think about the coverage again. So blue bar is the proportion of the girl who has access to the vaccination. So roughly speaking, by 2022, almost like half of the girls have access to the HPV vaccination in African countries, which is good compared to the global average. And if you take a closer look here, I should have put the figure here, but 31% of girls were actually vaccinated in 2022. This is a great achievement in African countries, but we need more effort to reach 90%. And also, I'd like to quickly touch base on this topic about WHO position paper, which was updated December 2022. As you already know, so we updated to include option. The 1-dose schedule is available for 9 to 20 years old. This allows the country to overcome a lot of challenges. As Dr. Bagudu already said, like, for example, financial barriers, logistical challenges, supply constraints. So these are the big headaches for the country to introduce HPV vaccine and to achieve high coverage. But if you have a 1-dose opportunity, and now you have evidence that 1-dose is as effective as a 2-dose schedule, so many countries are switching and adapting to 1-dose schedule to reach more girls to the HPV vaccination. So this WHO position paper was issued 2022 December, and also please don't forget these population. For example, HIV positive population, because this is the population who is very vulnerable for the for the cervical cancer, because this population is 6 times higher to acquire a cervical cancer compared to the normal population. So you have to continue 2-dose schedule for this population, ideally 3 doses. And secondly, we have a secondary target cohort. This is a conditional conditional target cohort. Let's say, if the vaccine is feasible, if the program is feasible and affordable, you can vaccinate boys and older women. So this is the position paper that WHO has issued 2022 December. And just going to the map again, and you see that orange one is the country that has adapted to the 1-dose schedule. You see a lot of countries has already switched to the 1-dose because of following the HPV position paper in WHO. You can see a lot of African countries has already adapted, but not only the African countries, but also a lot of Latin American countries here, and Asian country, and also you see a high-income country like Australia and the UK, Ireland, Estonia. So many countries has already switch into the one-dose schedule. So you see that currently, as of today, 38 countries have switched to the one-dose. So that's, things are changing, and after the HPV position paper was issued. And I'd like to switch the topic to introduce a couple of tools that to support the countries to introduce HPV vaccine. So looking at the available tools, so this is at the homepage, our WHO homepage to show the available resources. I don't dive into the detail of each document, the resources, but I just want to deliver the flavor, what kind of document or what kind of tools and guidance is available in our WHO department. Like I said, position paper, of course, this is publicly available. Not only that, for the we have the PowerPoint to showcase. So this is the evidence, this is a study, this is a systematic review. So this kind of like a product is also available. And in 2024, this year, we are thinking about to develop a framework about the secondary target cohort. So as I said, if the resource is available and feasible, you can vaccinate to boys or older girls. Then the question is, which cohort should be prioritized? So of course, 9 to 14 years old girls, that is a primary target. So after that, which way do we go? Do we vaccinate boys? Do we vaccinate older cohort, like a 15 to 20 years old? So we are trying to do to understand what is the optimized way in terms of like efficiency of the available resources. So this framework will be available 2024 this year. And also for the decision-making perspective, so we have a cost-effective tools. This will be updated to incorporate one of those perspectives. And we have an opportunity to do some, the presentation and the capacity training for the NITAC global network. And one thing I would like to highlight is that currently we have an introduction guidance. So this is a document, if you want to introduce HPV vaccine, this is a document you can refer to. But this one is like a 2016. So now we are considering to update to 2024 version, because in the last 8 years, we have experienced a lot of experiences from the country. And also we changed the global HPV position paper to encourage one of those recommendations. And also we have a cervical cancer elimination strategy as well. So now is the time to update this, HPV vaccine introduction. So stay tuned on this topic. And also budgeting. Budgeting is also very important to program to include HPV vaccine into national immunization program. So this is a tool to budget the cost. How much does it cost when you include HPV vaccine? You need to put like the product, you need to put the schedule and the number of the population, for example, so that you can understand the total amount of the budget for the HPV vaccination program. This is what we call C4P, cervical cancer prevention control and costing tool. So I'd like to briefly touch upon the supply situation because there used to be, let's put it in this way, there used to be a challenge about the supply constraint. I know a couple of countries had to wait a couple of years to introduce HPV vaccine because of the supply situation. And we regularly update, the global HPV supply situation, and we can say it's improved because of the expansion of the pharmaceutical company capacity. And also you have an opportunity to switch to the one dose, which leads to decreasing the demand of the HPV vaccine. This, the increase of the supply and the decrease of the demand is working in a good direction, so that in the midterm, we can confidently say, okay, supply is no longer an issue. So even like a short term, so the country are leaning to, one dose area, which is green here, so that now you don't have to care about the supply when you, supply is not a reason to wait for the introduction. So supply is definitely getting better. So I would recommend don't wait introduction due to the supply. And this is a slightly overlapping slide with Frederick, just she already presented. But so this is the area that Gavi has shown that this is a gap approved by, excluding this Gardasil 9, Seclin, Gardasil, Subrix. These 3 products are available through the Gavi pipe and the purchase from the UNICEF line. And globally, currently 6 products are available, and these 4 are fully qualified by the WHO. I don't want to repeat the detail, but if you compare to, for example, like cost for the vaccine is like described like here. And also, I'd like to highlight which vaccine can you use for the 1-dose schedule. So currently, we have data from the, evidence from the Subrix and Gardasil 9. And we are waiting for the result from Seclin, which is expected in 2025. So this is the, the product that we can use for the HPV vaccine. And the next available tool is that behavioral science and behavioral and social drivers of HPV vaccination. So when you look back the first presentation, there's like importance of the raising awareness, or the importance of how do you deal with the misinformation. So this is the tool to understand why were you get vaccinated, or why didn't you get vaccinated, to understand people's behavior, to understand what is the reason for the high uptake, what is the reason for low uptake. So this is a tool to understand people's behavior. The WHO already have, this BSD tool for the childhood vaccine and COVID-19 vaccine. And this year, we are trying to create the HPV vaccination tool for this one. So this is also very important for the country to understand the behavior, increase the uptake. So this is, lastly, I'd like to show to, a little bit future looking. What is the research agenda? What do you have to think about for the future? What is the remaining question in the current situation? Let's say to improve HPV vaccine coverage. So we know that many countries successfully introduced HPV vaccine. But thing is, the introduction is not the goal. The goal is to achieve high coverage. So even after the vaccination introduction, it's very difficult to achieve the high coverage. You can say how many countries has achieved 90% of the coverage. It's quite low, like 4, 5, 6 countries have only these countries have achieved very high coverage. And even it's very difficult to sustain such a high coverage. So what can we learn from the past experience? For example, like integration of the services. There is a country that has, the available platform, for example, cervical cancer screening services. How can we integrate these vaccination services and screening services? How can we strengthen each other? This kind of like a research agenda meeting was held in August, and we are going to, prioritize which research questions should be deal with in the coming months. So this is a future-looking topic about this topic. And lastly, I'd like to share a couple of our thoughts. Let's say, what is a key role for the research institute or researchers or advocates in this cervical cancer elimination area? So of course, it's very important to support MOH and the EPI program, which is based on the evidence and the decision-making to accelerate HPV vaccination. For example, of course, WHO has a position paper to recommend, okay, 1 dose is enough. 1 dose is enough now. So this is the evidence. But still, you have to kind of like adapt the global standard to the local context. For example, there is a large population for the HIV positive population. And the prevalence is slightly different country by country. And each country has each context. It's important for the research institute to understand, to adapt the global recommendation to the local context, and also contribute to the knowledge base by conducting research about HPV vaccination. For example, as I explained, so what is an opportunity to enhance the uptake of the HPV vaccine through other intervention. And lastly, as a professional, it's very important to communicate, well prepared to communicate about HPV vaccine. So you need to have to be prepared for a Q&A by teacher, by parents, by girls. So it's as a professional, it's better to be prepared to communicate with these population to tackle with the misinformation or vaccine hesitancy. So that's just a concluding remark. So this month, January, is a cervical cancer awareness month, and I just put it here. So I don't explain one by one, but this is my, the conclusion of the presentation. But thank you very much for your opportunity, and happy to discuss further into this topic. Thank you very much.
Thank you so very much for that very insightful and informative presentation, Dr. Hiroki. And thank you, everybody. We've stayed on for the call. We still have another 24 minutes on the call, in which time we're going to be discussing some of the questions that have been raised or some of the concerns that you may have as a team. We've listened to Dr. Shinkafi Bagudu, who is a consultant pediatrician and an advocate for women's health earlier today. She took us through Nigeria and the case presentation of what Nigeria faced, how they were, the challenges they faced in introducing the vaccine, the opportunities that they had in engaging various stakeholders, and the very high coverage rate that they received, that they got in the 16 states that they introduced the vaccine, and of course the optimism for the upcoming other introductions in the remaining states. I need to remind you that Dr. Bagudu was also the First Lady of Kebbi State, 2015 to 2023, and she collaborated with state ministries of health, education, and women affairs in implementing sustainable programs aimed at improving women's health. So she's quite a resource to this team, because when we're looking at also introductions to in-country vaccinations, we could learn on how they had advocated for government uptake and high government buy-in in cervical cancer elimination and in other cancers as well, including breast cancer. Very good information from our three speakers. I'm going to open the floor for any questions that you may have. I've seen some others were asked on the chat and were responded to. So anyone with a question, please just raise your hand or unmute and speak. Thank you. As we're waiting for people to get their questions together, and Dr. Bagudu, you're also welcome to ask questions to our other panelists, as well as Hiroki and Frederique. Feel free to also ask questions. As we kickstart the set of questions, just two asks to our presenters. The first one is, you had brilliant, amazing presentations, and you had links to various sources of information that we could utilize. Would you kindly share them on the chat so that people can be able to pick them up? And then directly to, I'll start with Dr. Hiroki. If you would kindly just tell us, when you look at from a WHO perspective, we in Africa have the challenge, as was highlighted by Dr. Bagudu, that myths, misconceptions, and challenges of misinformation, disinformation have constantly plagued our continent. And so when we introduced the vaccines, for example, Kenya introduced in 2019, we have the challenge that the girls who were at 2019 age 14 were eligible for the vaccine, but because they were not eligible for the next cohort, how potentially be able to cover such girls who were missed by the current funding cycle for the cohorts? What are your thoughts from a policy perspective? Dr. Hiroki.
Yeah, thank you very much for your very good question. So as you said, so there's a lot of challenges about the misinformation, but let me say this is not only African country, but it's a global concern. Like my country, like let's say Japan, the coverage is like very low, 1%, let's say. Yeah, it's quite very low. So just an example, how do we catch up this missed cohort? So that is a very difficult question to answer. There is no like a golden standard for to respond to that question. But there is a country that to conduct the catch-up campaign for the missing cohort, using the opportunity to do the MAC vaccination in the, as you remember in the Gavi presentation from Frederick, there is a country who is doing the delayed MAC. So that is one of the opportunity. If you have an opportunity to do the delayed MAC, you can leverage that opportunity to call the population who should have been vaccinated. So if your country has an opportunity to leverage the MAC vaccination, that is the time. And also, what we often say to the country is that as long the WHO recommendation is the priority is 9 to 14 cohort, 9 to 40 years of age. That is a primary target of the WHO. But some countries are saying, okay, we are targeting 9-year-old. So next year, I'm 10 years old. I missed the vaccination last year, but can I vaccinate it? Some countries say, no, you are out of the target cohort. But our recommendation is you can vaccinate up to 14 years old as much as possible. If you miss the vaccination opportunity, you can come back and get vaccinated. That is the message from the WHO. Whatever the age, if you have an opportunity, you can get vaccinated before turning to the 15 years old. That is a strong message. That is the reason why we are prioritizing 9 to 14 girls of age. Of course, there's the dilemma between the WHO recommendation and the national policy. We understand, but our position is it's better to catch up before turning to 15 years old if you miss the vaccination opportunity. So these are the my personal experience and the WHO's recommendation. So I hope this clears your question, but this is very hard to answer. Thank you.
Thank you so much. Yes, you have cleared, and that's quite useful for our even advocates on the call when we are talking to our governments about policy and about the government recommendations. It's quite something that we can also be able to utilize to speak into that question of missed opportunities and missed goals. Frederick, over to you. When you look at civil society such as Dr. Bagudu's organization, which has done tremendous work in Nigeria, and you can hear that the misinformation, the myths, the misconceptions was one of the issues. But secondly, there is the issue of also having resources directly dedicated to civil society action for supporting elimination. My question is two-pronged to you. There is the 2025 target for 86 million girls vaccinated. And where are we at on that? We are in 2024 now. Where are we at on that? And in this year, with the targets that you've set, and you said April is the last time to apply to be able to contribute to the 2025 target, what can countries, civil society, advocates do to support the 2025 goal, and what resources are available to support such initiatives? Thank you.
Thank you. It's a very rich question. Yeah, asking. So yes, indeed, we do see that civil society has kind of an important role to play as we have different stakeholders. So we really are fully convinced that in order to make this a success, we really need to come together to contribute. And we have been thinking and do have some channels then also how to support that work by civil society. Now, I can't give you kind of the one easy answer because one would have to see in the given context how that is. But kind of a good starting point is that most countries have like an immunization coordinating body or committee, which is there, which should be engaged around the discussions on how to take this forward. And that might be a very good entry point then also to say kind of like, okay, what is planned? How do stakeholders come together? And how do we ensure that the relevant voices are heard and kind of we really come together to make this a success. There we do have, it is entirely possible also that through Gavi's resources, kind of civil society organizations can actually access resources, be it through kind of, as I mentioned, TCA mechanisms, where some of the even ongoing existing technical assistance is actually provided by civil society organizations or through the HSS support. You were asking the question, how are we doing with the targets? I would need to check what kind of is exactly the latest in terms of reporting, but actually it seems we are doing fine. So we are kind of carefully optimistic because we also know that there is this lead time, right? So, but if we are thinking like already kind of with the efforts in Nigeria, where can Dr. I was also carefully optimistic about this. And if we kind of also project with the similar careful optimism about other countries' efforts, we do really think that that goal is achievable, even though we also recognize that it really kind of requires a massive effort from all of us kind of pulling into this direction.
Okay.
Yeah, I'm going to pause there, but please let me know if you want me to kind of dive into a specific component further.
So thank you. And Dr. Bagudu, you have been in the space quite a while, sitting on various boards, sitting on various technical expertise tables to discuss the women's health, not just cervical cancer and not just HPV vaccination. Could you give us insights? And because I'm asking this because I know you sit on various technical teams as well as in various boards. And so looking at integration and HPV vaccination, often in Africa, we look at singular approaches to the work that we're doing, but sometimes we may miss the opportunity to integrate into other initiatives that are working. What would you say to this team from a research perspective, from a implementation science perspective? What insights do you bring to the table on integration and how that could support HPV vaccination?
Thank you, Brenda. Certainly, the work that I've done in the past in various capacities has given me the ability to view things with different lens and different perspectives. Like you mentioned, I've been in the political sphere aside from my professional backing. So sometimes it's easier to understand where people are coming from. Yes, we do often have programs in silos in Africa, but in having been on the side of government, I can say very confidently that it's not always the fault or it's not always the way we wish it. Today, you have one partner comes with a program that is focused on HPV self-sampling. And then you have another partner comes with a program that is talking about test kits for HIV. They haven't spoken to each other. They haven't synergized. So it's up to us to be very clear about the terms of entry for all the partners that are coming into the country, both at the national and subnational level. And one of the easy ways in which we can do this is by improving our ICT system. If we have national dashboards, if we have dashboards that everybody they exist in theory, but not practically, such that any, I don't want to mention names. Okay, Gavi and WHO are on the call, so I can mention programs, and they start then the implementation, but it's not actually talking to each other. More and more with the advocacy and the agitation that has been seen, and of course the obvious effect of having extra cost implications, that is beginning to happen, which is why we're hearing a lot of conversation about twinning cervical cancer services or into women's health clinics that are existing, particularly those in the HIV/AIDS space. And it's just common sense and it's a win-win situation, an economically sensible one to piggy bank the cervical cancer screening as well as early treatment in our HIV or even maternal health clinics so that you can have a one-stop. I believe that we should continue to talk about it. We should continue to agitate for having those implementations to our governments, to our partners, and we will definitely see more improvements. It makes sense because you have women that are living in faraway places. They don't have easy access to hospitals or had to navigate roads, and she can only make that trip once. I've seen the screening program by Electa Foundation in Rwanda. It's amazing. Very hard to navigate areas, but they're doing everything as a one-stop, plus some empowerment of the women. They give them practical skills and so on, and it's easier for them to come, do the screening, at the same time get some training. They go back, and then if they have to call them back for early treatments, it's easier for them to get them back. So for the women, the point I'm making is it's easier if we can get them for one clinic to come and do everything, or the same place offers it and there's some ability, they know that it exists. Usually the most sensible argument or the winning argument is when you make a financial case for anything. That way we'll be able to see it done, because we just don't have the resources to go around all the various programs now.
Thank you. And so what I'm hearing you speaking into is sort of an intergovernmental coordinating mechanism that brings all stakeholders on the table to be able to have conversations around economies of scale if we integrate and put together programs that are working in women's health. Thank you so much. Now I'm recognizing the time, and I know this subject matter cannot be covered in 1.5 hours with such powerful presentations and be able to cover it in totality. So what I'll ask everybody is, unless you have a really burning question, in which case then you can unmute and speak into, I would ask that we will continue this conversation with this team and be able to forward any questions that you have if you send them through the KENCO Secretariat, and we can be able to continue this learning process together. I know I'll be following up on those links so that we can also be able to share them with the various stakeholders that we work with so that they can also benefit from the conversations that we've had today. I'm grateful for this opportunity. Dr. Bagudu, Dr. Hiroki, Frederique, thank you so much for your time. Thank you so much for pulling together such powerful presentations in January when everything is up in the air and in such short notice. We really are grateful to you. I want to hand over to Charles Moya from the Secretariat, or to Teddy. One of them will take us through the announcements and any other conversations that need to be had from the ECHO Secretariat. Thank you all for staying on, and thank you for learning with us. Thank you.
Thank you.
Thank you, Benda.
Yes,
thank you, Benda.
Nancy.
Today is me who's sitting in for Charles. I want to thank each and every person that has created time to be part of this session today. A special appreciation to all the facilitators and the participants. The next session will be held on 15th February. Be sure to be part of it. Yeah, and the session materials will be sent at a later date. Yeah, I want to thank you all for being part of the session. And yeah, thank you.
Thank you.
Thank you very much.
Thank you for the organization.
Thank you all for your time.
Thank you very much for this opportunity. Thank you.
Thank you.